Good afternoon, my name's Catherine Harrison. I'm one of the infection control nurses and I currently work for Leeds Community Healthcare Trust and GP Confederation. The aim of the slides today are going to talk around infection prevention control and the importance of the implementation of the national cleaning standards. So aim today is to understand infection control issues related to the cleanliness of healthcare premises, your responsibilities around that and how to implement evidence-based safe working practices within your relevant areas. Predominantly within the environment, we talk about the patient and some specific organisms. Objectives, we're going to discuss the importance of cleanliness interlinked with infection control and the maintenance of safe healthcare environments, some microorganisms and their requirements and the mode of spread. We're going to talk about cleaning in general and decontamination principles and methodologies, the importance of hand decontamination, the correct and safe use of personal protective equipment, and the safe management of healthcare waste, ending with the overview of the National Standards 2021. As an overview, I'm going to discuss how vital your role is within all this criteria. All users of healthcare premises and staff working within areas have a right to assume that their environment is one where infection hazards are adequately controlled. In linking with that, the cleanliness of the premises is key for infection prevention and control, and this plays an enormous essential role in ensuring the safety of your environment for both your patients, staff and all of your visitors within those areas. Cleaning is the responsibility of everyone and we all have a role to play in ensuring standards and safety are maintained. Everything around what we do is governed by the Health and Social Care Act. The importance of the standards makes recommendations of highlighting risk within areas, making sure we are highlighting who is responsible for cleaning, what, where and when, and how frequently. As you can see on some of the slides, what the eye doesn't see. So things may look pretty clean, but things like walls, floors, broken areas that you can't clean appropriately, those harbour bacteria and germs and bugs. And obviously we want to be able to clean those areas efficiently. So it's really important that we have a robust system in place to make sure that we're doing this. Cleaning, what does that mean? The physical process used to remove organic material and organisms. However, just general cleaning does not necessarily destroy infectious agents. So we need to use sometimes neutral detergents and water or detergent wipes. Cleaning is a prerequisite to effective disinfection or sterilisation. So do we know the difference? Decontamination is a process that removes most contaminating organisms depending on the process used. Cleaning is always the first step in the process and can be followed by disinfection and sterilisation. Disinfection can be described as a process that's used to destroy, reduce most microorganisms. It is a selective process and depending on the chosen method, either heat or a chemical, may not inactivate some viruses and bacterial spores. So in essence, some bacteria and some spores are more difficult to clean. Therefore, we need to use a different process to enable us to clean that more efficiently. So sterilisation, for example, is a process used to destroy and remove all organisms, including spores and viruses. Effective cleaning is essential before sterilisation. This slide is just an example of some of the people that may have some vulnerabilities, and when we're dealing with these patients, we need to make sure that the environment remains clean and the risk is reduced. For example, a newborn baby, an elderly patient with a leg wound or a catheter, or an immunosuppressed patient that's receiving chemotherapy. The next slide just is a bit of food for thought. Did you know we shed 28 grams of skin every 2 weeks? And in 5 years, our pillows increase in weight by 20%, mainly due to dust mite excrement and our skin. And an average used mattress has 10 million dust mites living in it. So if you think about that, and you think about the different types of bugs that we can live with, some bacterias, viruses. As you know, we've just had the recent pandemic of COVID. We have flu. There's parasites that we can get infections from, prions and fungi as well. Those are just a few of the bugs that we align to and live with. But however, if we become more vulnerable and we get a portal of entry, then we can become very unwell and perhaps sometimes get infections that we don't want. Here's just an example of the chain of infection, and as an infection control nurse, this is one of the main things that we would look. So what we want to do is break the chain of infection and therefore stop the infection, making people become very unwell. So, for instance, we have a microorganism, which could be COVID-19. That needs a reservoir to live in, predominantly. That could be in your nasal cavity, in your chest, or in your throat. It then needs a path for the reservoir to move from one place to another. So that could be, it lives in your throat, but it needs a mode of transmission to move. The mode of transmission might be coughing, sneezing, touching surfaces, and then it needs a portal of entry. We talk about the portal of entry. So say for instance is COVID. Somebody could be coughing, sneezing, the droplet and airborne particles would then be transferred into somebody else's eyes, nose or mouth. And then that makes you then a susceptible host. And predominantly then you could get that infection, and then that's how it's passed on. When we think about bugs and viruses and bacteria, if we take bacteria as a whole, we need food, we need warmth, we need time, and we need water for it to evolve and grow, the stuff of life. That's why we always incorporate hand hygiene as the most important effective measure for preventing the spread of infection. These are just some examples of bacteria. So if you look at the plate, you can see that's a ring shape. That's why we say people should be bare below elbows so they can wash their hands effectively. So that's some Staph aureus growing on the plate. The other is the scales of skin. And the other slide is an example of when people haven't washed their wrists properly. I'm sure you've all at some stage done the glow light test. So how good is your hand hygiene? These are the 8 steps that we should be following, and they're the National Patient Safety Advisory ones. You can use soap and water, which is the most effective way to wash hands, but you can also use hand rub and gel. So going back to how good is your hand hygiene, do you know what the 5 moments are for hand hygiene? Before touching a patient, before any clean or aseptic procedure, after bodily fluid exposure risk, after touching a patient, and really importantly, after touching a patient's surroundings. Hands must be decontaminated immediately before and after every episode of direct contact with your patients, including aseptic procedures. Hands should also be decontaminated after every episode of direct patient contact or care, to any exposure of blood or bodily fluids, and after a contact in patient's surroundings, which is really important because if you don't, it could result in hands being contaminated and immediately after gloves. So you must also wash your hands immediately when removing your gloves. Staff, if they're patient facing, should always be bare below elbow. It should be short sleeves, rolled up above the elbow. You must remove any wrist watches, avoid any jewellery. You should have one plain band, which is acceptable. Nails should be kept short and clean with no false nails or nail varnish. And this is guidance from the Department of Health. The reason behind that is so that you are able to wash your hands effectively. Personal protective equipment. So we tend to use gloves, aprons, surgical masks, eye goggles, face visors and respiratory masks. These are all examples of PPE, personal protective equipment that may be worn in the provision of healthcare. It can be used in healthcare settings to create a barrier between the healthcare workers and an infectious agent from the patient and reduce the risk of transmission of microorganisms from healthcare workers to the patient and vice versa. You should always choose PPE based on a risk assessment, i.e. when you're looking at risk to exposure to bodily fluids, blood or infectious agents. It should also be available at the point of use, and staff should receive training on the correct use and the disposal of PPE. Using inappropriate PPE can increase the risk of transmitting infections and put people at risk of acquiring an infection. So the correct use of donning and doffing must be undertaken, and there's some quick guides on these slides to show you through. I'm sure most of you are aware that when you're removing your PPE, that the gloves must be removed first, as these are the most infected or dirtiest parts of your PPE. Know your colours. All cleaning should be made into a colour-coded system or scheme. Different colours for different areas, as you can see. And the national colour coding scheme should be displayed within your cleaning areas of your department. Here's an instance of how to make up a disinfectant solution also. So if you've got a terminal clean, an infectious clean, an outbreak of diarrhoea and vomiting or C. diff, then you should be using an agent like this to clean, a chlorine-based solution. And it can be used with disposable cloths or mops, and it can be used also to disinfect frequently touched surfaces and floors. When to use Connell Universal Wipes. You can use on all other reusable equipment after each patient use, and use indicator notes when cleaned if you wanted to. Some equipment has manufacturing instructions and that must be followed. Cleaning technique. We recommend you wear appropriate PPE and use one wipe from the pack. You work in an S-shaped motion and you clean from top to bottom, or dirty to clean. And then you must let the surface air dry before popping them away. Do you know where your spill kit's kept? And do you know how to use it? This is a really important piece of kit that should be in every practice or in every area in case of any accidents of blood or bodily fluids. It is the clinician's responsibility to clean up blood and bodily fluids. The cleaning staff won't clean this initially, they'll clean afterwards. So it's really important you find out where your kit is, if it's in date, and how to use it. You must dispose of your waste accordingly, and there's a colour-coded system. This is not exhaustive, and I know some practices may not use orange or they may use yellow bags. Yellow and black is used predominantly for offensive waste or hygiene waste. Purple again is cytotoxic or cytostatic, and then black is just general domestic waste. There's some numbers on there for the City Council Waste Hotline if it's needed. For any domiciliary setups. So if you're wanting a patient to have their own waste, for practice nurses, that's the number. You can organise them to have waste at the home address, or if they're just coming into practice, then you just dispose of the waste accordingly. And as you're aware, the new National Standards of Healthcare Cleanliness have been introduced in 2021, and these replace the 2007 standards. So this document, it highlights mandatory requirements, cleaning frequency gap analysis, documents required for implementation, and a 10-step implementation plan. Mandatory requirements include functional risk categories, elements, frequencies and performance parameters, cleaning responsibility, audit frequency, star ratings, efficacy checks, and a commitment to cleanliness charter. All of these were led by Emma Brooks, Head of Soft FM Strategy and Operations, NHS Improvement. And they're a working party from across the industry that have come together with health and safety executives, infection prevention and control nurses, nursing, clinical and microbiologist leads, and they've all come together to look at these standards to make sure that they're equitable across the board. The National Standards of Healthcare Cleanliness replaced the National Specifications of Cleanliness, NHS 2007, and the standards are applicable to all healthcare settings and the process will create opportunity to review your cleaning policy to ensure that they meet the minimum safe standard. What they're trying to do is seek to drive improvement across the board, but it's flexible enough to meet different complex requirements of all the different healthcare organisations and sectors. So each healthcare establishment can decide how their cleaning resources are best organised. So your mandatory requirements, as I've said before, is around functional risk, elements, frequencies and performance, cleaning responsibilities, audit frequency, star ratings, efficacy check and the commitment to cleanliness charter. There's also a suite of documents to support. The appendices are really important because they have documents, charts, audit tools in there for you to use, so you don't have to create your own. It's all there for you to use and to implement as you need to. In 2021, the standards reflect a modern method of cleaning, inclusive of infection prevention and other changes since the last review. And also this is inclusive of important considerations given we've just had a recent pandemic. The standards emphasise transparency, and it's a way of assuring patients and the public and all the staff that the standards of cleanliness have been met. And they need to be in a collaborative approach. And by taking this approach, it makes it clear to patients, staff and visitors how clean your area is and encourages collective responsibility, which ultimately inspires people to work together to achieve high standards. All organisations must implement the standards, and there's a set timeline for 18 months. Where the standards were not previously applicable, organisations will need to assess the implications, but there must be an implementation plan on an individual basis, and organisations can operate above the baseline if they choose to do so. All of the healthcare environments that we work in today should pose a minimal risk. That's to patients, staff and visitors. However, because every different department has a different functional area, i.e. a department or building within an establishment, they do not carry the same degree of risk. They will require a different cleaning method and a different cleaning frequency. Identifying your functional risk for your functional areas is the first step and is really important because this monitors the cleaning frequency, your audit frequency and your target scores, and it's all directly linked within this categorisation. There used to be 4 categories, but now this is increased with the new standards. There's now categories 1 to 6. Organisations can remain within their existing scoring regime if they choose to do so, but expanding the score enables them to increase or decrease the rating in individual areas as appropriate, to facilitate better use of resources or to recognise the cleaning of an area needs to improve. You can also use a blended risk approach, and that's a new category within the standards. As you can see, FR1 will be a very high risk category, FR6 will be low, and a blended is a new risk which sites outside the 6 ratings percentage for a blended approach is based on the combined targets of rooms in each functional area. So for example, if you've got a practice with 7 consulting rooms, you might blend all them 7 within a score of FR4, and that would give you your audit score and your audit frequency. But you would need to attain 85% within all them 7 rooms. Governance for functional risk areas. The adoption of all 6 categories is not mandatory, and it's unlikely that in practices you would use all those scores. The standards provide a guide, and that must be locally decided because as you can see, a hospital would not be the same as a GP practice. The risk would predominantly be lower. Whether a healthcare organisation is to adopt the 6 categories or the blended approach, it must ensure all the documentation outlines the allocation process and how you've done this. So there should be a written rationale for how your risk category is being derived for each room area or if it's blended area. A written rationale for how the risk category is being derived, that includes each functional area or room group of rooms if blended. Regular review of the functional area, so that means if you're introducing any new services, you look at the risk. Is that risk higher? Does your functional risk need to be increased? And a written record of the functional area review. Functional risk categories. So there's a list here of all the functional risks and which sort of services or areas might meet that functional risk. So as you can see, a functional 1 risk is the highest risk. That includes chemotherapy, immunocompromised units, delivery suites and operating theatres, and so on. Your lowest functional risk might show administration offices, medical records room or a stores department. Now we move on to the elements performance parameters and your cleaning frequencies. Once you've identified your risk or your risk areas, you must produce a cleaning specification with a more detailed information of how cleaning will be carried out. Within the standards, there's 50 elements of around 50 items or categories that may require cleaning, and it's not an exhaustive list. And working within the GP practices, you're probably not going to have as many on the list as you would within a hospital or an acute setting. So some of the elements on the list may be non-applicable to you, and you would apply them to your standards. Performance parameters. So it's expected each element and standard after cleaning, all parts should be clean with no blood or bodily substances, no visible dirt, dust, debris or spillages. For instance, if you're wiping down a thermometer, let's say, that should be done before and after each patient, and it should be cleaned by the nurses, and it should be done daily. Cleaning frequencies should be broken down by your category as well. So the standards provide an example of cleaning specification as a guide, because it's not a single national approach. Every organisation will have their own items and it will differentiate. So it's all around the risk of your areas and the differentiation of your functional category, of how often things may need cleaning and who is responsible for that. So adapting an example of cleaning specification for local use is really important, and your cleaning frequencies can be tailored to suit your requirements. But it must not be reduced to below the levels. So for example, if you've got an FR4 rating, you must equivalate to those cleaning standards. You mustn't clean it any less than what it should be within that risk area. And there's an example. So walls accessible up to 2 metres, let's say, and you've got a risk of FR4. That states it should be a full clean annually, a check daily, and if there's any blood or bodily fluids or soiled areas on that wall, they should be cleaned immediately. And that the wall cleaning will either be down to your cleaners or your estates, and that would be decided locally between you and your practice or your sister practices if you're going to do it collectively. Cleaning responsibilities. All healthcare establishments must produce local schedules of cleaning responsibilities. Detailed items must be cleaned and who is responsible for cleaning each one. And the standards document clearly that they recommend which staff group is responsible for cleaning which element. But it is a shared, like I say, collective agreement locally, and this should be agreed at the outset. The following slide will show the sample of the cleaning responsibilities matrix, which can be used to suit a non-acute setting, or a local template can be used if preferred. As you can see, this cleaning responsibilities matrix outlines all of the 50 elements. Like I said before, some of those elements may be non-applicable to a GP practice or a primary care area, and it shows who is responsible, which area is responsible and what's been agreed. Audit frequency. So we can provide these cleaning standards, but we need to provide assurance that it's been delivered as it says within all the documents. The audit scores for each functional area are represented in 2 ways, a percentage score or a star rating. Percentage score is for internal verification and scrutiny that a safe standard has been achieved, whereas a star rating is for external verification of this. Percentage scores are still split by responsible staff group, i.e. cleaning, clinical medical, estates. as locally agreed as above. So as you can see, if you've got an FR4 room, your audit score should be 85% and above, and you should be auditing those areas every 3 months. These audit frequencies within this table are just a guide and can be increased to meet the standards if you feel it's necessary. So the audit process must never be decreased. If you've got a FR4 rating, you wouldn't audit it every 6 months. Star ratings are widely used in industries, as you well know, such as hotels, restaurants and media. This allows public perception to see, actually, oh, that's a really good facility because it's got 4 or 5 stars. Star ratings are simple and effective, and they use meaningful information about the quality. And that's what the new cleaning standards are around. They're about allowing patients and visitors and relatives to be assured that cleaning is up to standard and is safe within that organisation. It is recommended that star ratings are only displayed in areas accessed by patients and where they may be visible. These are examples of the star ratings and can be found in the appendices of the cleaning standards. It may seem a strange principle to enunciate the first requirement in hospital, that it should do the sick no harm. This is a statement from Florence Nightingale in 1859, a lady that we all know and we know very well. This is a really good link to cleaning and infection prevention, and it is essential to demonstrate the cleaning efficiency by auditing both the outcome of cleaning and process which the cleaning standards are achieved. The integrity of cleaning process is really fundamental to providing assurance that as an organisation we delivered safe standards of care against the standards of cleanliness. And to meet safe standards, the efficacy of the cleaning process is as important as the technical outcomes of cleaning, which is now an area of focus, and this is why the new standards have been implemented. The efficacy audit is carried out by the manager responsible for cleaning and representatives from facilities, infection prevention and control and clinical teams. The efficacy audit can be adopted locally to encompass local requirements and activity. Therefore, if you've got a company that are providing you with cleaners, then their cleaning manager must come and be part of this audit, along with your practice manager and your infection control lead. Currently, there is no pass target score. This audit focuses on the processes to achieve the outcome. And there's a sample template on the next slide which can be used in practice and draws up scores for you. This is the example of the efficacy check sheet. The Commitment to Cleanliness Charter sets out an organisation's commitment to achieve a consistent high standard of cleanliness in all its healthcare facilities. And by using all your functional risk categories, your cleaning frequencies and your responsibilities for each area, they can then provide this charter to give patients, relatives and anybody else entering your premises. You can edit the charter templates to insert your own logos and contact details. Some of the fields and headings you'll find are fixed and cannot be changed, such as cleaning tasks, frequency and responsibilities. This must be retained to appropriately inform patients and public and staff about the cleanliness, and they can then receive confidence that your areas are clean and up to standard. So it might not be practical to display the charter in some of your areas. It might just be displayed on your website, it can be displayed on your virtual page, or it can also be just displayed in your reception area behind your desk or wherever you find appropriate. But you must ensure visitors, staff and patients have opportunity to view the charter and understand how to give explanations for its purpose. And that's a commitment to cleanliness summary. So there's some things that won't be applicable, but like it says in the data, you can change it, move it round, and it just reflects your risk category and how frequent things are cleaned, and also gives you a score of cleaning also. This is just a whistle-stop tour of the new cleaning standards. The 10-step implementation plan supports people to implement the standards and put them in place. There's lots of documents that you can utilise, that you can use. and lots of information to help to guide you through it. Implementation timescales, it was saying that 18 months for mental health and all other categories, and ambulance trusts currently exempt as it's a separate piece of work, and that's already started. There's a healthcare cleaning manual also, which incorporates the standards of cleaning, general principles of cleaning and disinfection, cleaning methodologies, there's posters, there's videos, and there's also written pieces to support cleaning staff, nursing staff and estate staff of what to clean, how to clean and how frequently to clean. This last slide moves into the GP Mythbuster on the CQC page. I'm sure you've all read this page, but it explains that the National Standards of Healthcare Cleanliness replace the 2000 specifications. There are no expectations that we require star ratings or logos to be displayed in general practice. That means that they will still regulate you against the Infection Control Guide Regulations 12 and 15, which will incorporate all those things around cleaning, waste, audit processes, schedules and maintenance of equipment with your risk assessed standards in place. Thank you for listening to this presentation. Hopefully it's helped and incorporated the new cleaning standards and adopting them into general practice or general establishments or practice establishments across primary care. There are lots of resources to be used. Also, you can contact myself on catherine.harrison34@nhs.net if you require any further information. You're able to download the slides and click on the links also for further information. Thank you for listening.